Good evening, everyone. My name is Dr. Sachin. I'm an orthodontist, and today we are going to have a continuation class on the methods of gaining space. So, before we jump into the class, a quick recap on what we did last time. There are basically 7 methods of gaining space, and the first one that I used is basically a space regaining method. So, going back to the points, the first one is the use of T spaces and leeway spaces. The second method of gaining space is interproximal reduction. The third method of gaining space is arch expansion. And the fourth method of gaining space is crystallization. And this is where we ended our class last time. And today's class is basically going to be about extractions, derotation of posterior teeth, molar uprighting, and proclination of anterior teeth. So in the last class, before we proceed with today's class, in the last class I was asked about ACCO Appliance. So I would want to go with ACCO Appliance initially and then proceed with the class. So what basically ACCO Appliance is, or what is ACCO? AC stands for acrylic, C for cervical, and O for occipital. So ACCO Appliance is an appliance that is basically a splint that was developed by Margolis. It has a molar tube, a headgear tube of molar, and splint for the maxilla, and this is attached to a headgear. So now, if you can see in the picture above, that is how an ACCO appliance looks intraorally on the dental arch. And below, you can see 3 pictures. The last one, or picture C, is what is your ACCO appliance, the headgear, that is your cervical and occipital headgear device. So the picture on the top goes intraoral. Picture below on the right side end, that is the picture of C, is what is used for the headgear for the ACCO appliance. So the diagram of A and B is also put so that you understand there are also digitalization methods. The picture A shows you a headgear of an occipital pull headgear. Picture B shows you a cervical pull headgear, which is also used for digitalization. And picture C is used for your cervical and occipital or a combination pull headgear. So this is one topic that I missed during the last class for digitalization. So let me just brief up on how headgears work as crystallization and what all you need to know, including what their parts are and how your biomechanics work as well. So whenever you have a headgear, what it is it is attached usually to the maxilla, to your headgear tubes or to your arch wire. And you need to know the center of resistance of the maxilla so as to understand. So usually the center of resistance of the maxilla is in the posterior superior part of the PTM, or the point of the PTM, which is most posterior and superior. So if there is a force that is acting above the level of the PTM point or above the level of the center of resistance, as you can see in the above, which is given by your occipital pull headgear, there is an anti-clockwise rotation of the maxilla, whereas intrusion and distalization of the molars. When the line of force is acting along the PTM point, there is a bodily movement of your molars, that is, there is a distalization of the molars without hitting of the molars, and your maxilla also moves along center of line of force or along the center of resistance of the force. And this is given by your cervical and occipital pull headgear, which is a component of your ACCO appliance. So this is something that you need to know about ACCO appliance, that there is no tipping of molars and there is bodily movement of your dentition as well as your maxillary skeleton. When it comes to your cervical pull headgear, the center, the line of force might be directed below your center of resistance, and in which case there is a clockwise rotation, or the mandible, the maxilla moves downwards, and your molars also move distally and move occlusally. So this is basically how headgears work, and you might have photographic questions on it, giving you the line of force and the center of resistance and stuff like that. And if you know this diagram, you should be able to answer them perfectly. This was about ACCO appliance, and this was about headgears that was missed for digitalization. So coming to today's class, and this is how we continue. Your first topic for discussion on methods of gaining space for today would be extractions. So again, there are MCQs, and I would want somebody to answer them. The first question for today is, extractions are indicated when option A, there is an arch length tooth material discrepancy. Option B, there is an abnormal sagittal interarch relationship, meaning to say there is a class 2 or a class 3 molar and skeletal rotation. Option C, there is larger size and form of the teeth, and option B, all of the above. If somebody is online and if somebody would want to attempt the answer, I would wait for you. Coming back to the questions, extractions are indicated when option A, there is an arch length tooth material discrepancy. Option B, there is an abnormal sagittal interarch relationship. Option C, the teeth are of a huge size and the form are not fine. And option D, all of the above. Okay, the right answer for this question is option D, all of the above. And we'll discuss on how extractions are indicated and what kind of extractions are there in the future slides. I will just proceed with this questions for now. The right answer for this question is option D, all of the above. So coming to the next question, extraction space that are gained by extraction of first premolars can be utilized for or can be utilized by option A, anterior teeth, option B, posterior teeth, option C, both A and B, and option D, neither. Basically, the question is to say that when there is an extraction done, what can you do about the space? Is it only for retraction of the anteriors or can you also protract the molars? And if there is an extraction, what usually happens? So the question again is, extraction space gained by extraction of first molars can be utilized by option A, anterior teeth, option B, posterior teeth, option C, both A and B, and option D, neither of them. Anybody would want to answer? All right. So the right answer is option C, both A and B. So whenever you have an extraction space and extractions are no need to be, the option is answer C. So whenever there is an extraction indicated and there is a certain amount of space required for decrowding or correction of proclination, your anterior teeth are to be brought back, but to an extent where your soft tissue is also in line. So there is a new paradigm shift towards soft tissue, which is given importance than just the dental. So the right option would be option C. So you can initially retract your anterior teeth, and after a certain amount, after certain ideal parameters are achieved, you can protract your teeth. So extraction space can be used for both retraction of anterior teeth and protraction of posterior teeth. And the right answer is option C. Going to the next question, lower incisor can be extracted in the following conditions. Option A, if there is a Bolton discrepancy. Option B, if there is a blocked out incisor with good interproximal contact between central and canine. Option C, none of the above. And option D, all of the above. Anybody would want to answer this? Lower incisor can be extracted in the following conditions. Option A, when there is a Bolton discrepancy. Option B, when there is a blocked out incisor with good interproximal contact between the central and the canine. Option C, none of the above. And option D, all of the above. So I guess you all know what Bolton discrepancy is and how much it is important for stability. So in case there is a mandibular tooth material excess, which is almost to the amounts of a central incisor, say around 4, 5, or 6 millimeters, you can extract the lower incisor and close the space. And you also can achieve your canine relation properly when you extract the lower incisors for a Bolton discrepancy. Now, when there is a blocked out incisor, you can have a compromised canine relationship and you can extract the incisor if there is a good contact between a central and canine in the mandibular arch. So the right option for this question is option D, because if there is a blocked out lateral incisor, you need a lot of mechanics to work it on. And if there is a blocked out incisors, there will be a very severe arch length tooth discrepancy that is present, and the Boltons also will be usually not ideal. So the right answer for this question on where a lower incisor can be extracted is if there is one Bolton discrepancy, or if there is a blocked out incisor, be it central or a lateral, and there is good interproximation between the two teeth that are present in the arch. So the right answer for this question is option D, all of the above. Coming to the next question, the following extraction strategies can be used in orthodontics. So this is a question just to make you understand on what all tooth can be extracted and how it can be extracted routinely. There are literature of all the teeth being extracted, but then they're not followed now. So going back after this question, I shall explain more about it. So the question here is, following extraction strategies can be used in orthodontics. Option A, all four first premolars. Option B, only upper first premolars. Option C, only mandibular central or a lateral incisor. Option D, option A and option C, and option E, all of the above. So we all know that when there is crowding, that we do require extraction of teeth, and it is usually the first premolars, the maxilla and the mandible. Whereas if there is a class 2 situation, if the molars are in class 2, if the skeletal base is in class 2, and if the profile is fine, which is almost straight, then you can go with the second option as well. It is only your upper first premolar extraction. So if there is class 2, you can do your upper first premolar extraction as well. Now, when it comes to only mandibular central or lateral, I think the previous question gave you the answer on where you can extract your single mandibular incisor. And option D is a repeat. So option E, all of the above is the right answer. So you extract your first premolars or your second premolars when there is proclination, when there is crowding, and you need space around 8 or 9 millimeters or above it. You extract your upper first premolars only if there is a class 2 and you need to correct the proclination. There is sufficient amount of overjet and your profile is straight. You extract your mandibular central or a lateral incisor if there is Bolton discrepancy or if there is a blocked out incisor. So the right option is option E, all of the above. Okay, so this is a case-based question. I'll just read out the question and you can choose your answers. So the question says, a male patient with an arch length discrepancy of 7 millimeters requires extraction line of treatment. So it is clear that there has to be extraction that is done. It also has a grossly decayed 1/6. So his molar is grossly decayed. So which of the following extraction strategy is best suited for this patient? So the first option is extraction of all four first premolars and endodontic or prosthodontic replacement of the first molar, that is 1/6. Option B, extraction of first molars in the upper arch and premolars in the lower arch. Option C, extraction of 1/6 and then premolars of the other quadrants and lower arch. Extraction of 1/6 and 4/6, that is on the right side of the face, and on the left side, extraction of first premolars. So whenever you're doing a treatment plan, you need to be as conservative as possible. And whenever you're very conservative, the key to the answer is that you need to be very conservative. So coming back to the question and the options again, somebody, if you would want to try to answer it, do it. A male patient with an arch length discrepancy of 7 millimeters requires extraction line of treatment. So extraction is indicated. He also has a grossly decayed 1/6. The following extraction strategy is best suited. Option A is extraction of all four first premolars and endodontic or prosthodontic replacement of the first molar. Option B, extraction of first molars in the upper arch, lower arch, premolars. Option C, just 1/6 and the rest are first premolars. And option D, extraction of 1/6 and 4/6 and the rest are first premolars. Okay, so my conservativeness gave you all to choose the option A, but then when it is a grossly decayed teeth, you cannot endodontically treat it, so you will have to extract it no matter what. So when you extract your first molar, there is already a space that is present, and we can use the same space for retraction or for correction of overjet or crowding or whatever. So the right option is option B. Option C, extraction of 1/6, which is grossly decayed, and there is a huge amount of space that is available. So you retract your teeth as much as possible until you achieve sufficient jet, class 1 canines, and class 1 molar on the other side, and then protect the second molars and third molars if they are present. So since your 1/6 cannot be saved, extract it, do not replace it, use the same space, and in the other quadrants, extract your first premolars. If you have doubts on this, we'll get back to this again, and you can make a note on the YouTube chat if you want more explanation. The right answer for this is option C, extraction of 1/6, and the rest are first premolars. So this is a picture-based case question. The question being, the answer is in the question, but then question being, an adult patient has class 2 molar on one side, that is on the left, and class 1 on the other. What treatment options can be employed? Option A is extraction of all four first premolars. Option B, premolar extractions except on the side of class 2 in the lower arch. Option C, only the upper premolar of the class 2 side. And option D, all of the above. So the question is formed on this particular case. All of them are options that you can do if the patient has a class 2 molar or a class 2 subdivision. But then in this case, looking at the pictures on the top, they're your preclinical or preoperative photographs, what would be your best option? So as class 2 on one side, class 1 on the other side, what would you do? Would you want to extract all your first premolars? Would you want to extract all your first premolars except on the lower arch, which has a class 2 side? Or would you want to only extract the upper premolar in the class 2 side? Anybody wants to answer? You can look at the picture below. There is the answer there. So what they've done here is they've extracted all premolars except on the side of the class 1. So what basically happens is whenever you extract teeth, there is 8 millimeters of space that is gained. But overjet, if you can see in your treatment diagram, is not as much. Maybe it is around 3 or 4 millimeters. But then there is proclination and there is mild amounts of crowding in the lower arch. So if you extract your premolars in the upper arch, you will relieve your proclination. You will relieve your proclination, and you will achieve your ideal incisor position. Whereas in the mandible, we extract premolars on both sides. Then on the class 1 side, your teeth are retracted furthermore. Your midline of the upper and the lower midlines will be shifted, and it will not be in ideal position, and your canines will not be in the same side. So what we have done here is we have extracted your premolars on the upper arch. We have extracted the other premolar lower arch. We have extracted only one premolar that is on the class 1 side. So if you find a question similar to this, saying that there is a class 2 subdivision or a class 3 subdivision, usually you could go with using no extractions on the class 1 side rather than the other side, and you can extract the other teeth. If it is clear, I'll proceed to the next question. The right answer for this question is option B, premolar extractions except on the side of the class 2 in the lower arch. Okay, so indications of extraction and extraction as a method of gaining space. What all can you extract and how can you extract? These are what are usually done. And extraction of first premolars are usually done, and they are used for proclination correction or your crowding. Extractions of second molars are done, and when you are extracting second molars, you can relieve the proclination and crowding to a certain extent. And if you have class 2 molar relationship or class 3 molar relationship, your second premolar extraction will help you to mesialize your molars as well. So that is when you can extract your second premolars, and you can also extract them when they're decayed instead of going with your first premolar extraction. Extraction of a single lower anterior tooth to match your Boltons if there is any blocked out incisors, and in case you need to get your class 1 canines, you can do your lower anterior extraction. So if there is a class 3 situation, there is an overjet of 8 millimeters to 9 millimeters that is present. Class 2 situation, the molars are in proper class 2, your profile is almost straight or a little convex. What you can do is you can extract only the upper first premolars. So when there is a space of 7 millimeters between your upper anterior and your lower anterior, when you extract your premolar, you can push them back. You can achieve almost ideal overbite and overjet, and hence in your class 2 situations, you can extract only your upper premolars. Coming to your class 3, holds the same. You can just extract your lower premolars, and you can retract your lower anteriors to achieve a positive overjet. So in class 2 and in class 3, there is an option of only premolar extraction in a single arch. Class 2, it is the upper arch, and class 3, it is the lower arch. Now, when there is a subdivision case, class 2 subdivision, that is class 2 on one side and class 1 on one side, you can either do uni-arch extractions, that is, you can either extract only the premolar on the upper arch where the molar is in class 2 and then retract it. There is no crowding in the lower arch, or you can go with asymmetric or 3 premolar extractions as well in the subdivision cases. Now, extraction of canines, it is usually not ideal to extract canines, but then if there is an impacted canine that you can see on your OPG and it is unfavorable and you cannot take it out, or if your canine is grossly decayed due to caries, or it is traumatic, or it is periodontally compromised, you can go with extraction of your canines. And what you have to do after your canines are extracted is you need to reshape your premolars to the form of a canine. And premolar reshaping can be called as aesthetic contouring, odontoplasty, or anomaloplasty. So these are a few extraction methods that can be used to gain space or to correct the malocclusion. These are a few terms that might be asked in your questions. What are balancing extractions? What are compensating extraction? What is a Wilkinson extraction? Serial extractions, that is taken from periodontics again, which would be studying uni-arch or unilateral extractions. So what happens with balancing extraction is, if there is a extraction indicated in your upper arch and it's in the first quadrant and you extract it, sometimes the arch can be shifted, sometimes the midlines can be shifted and you will not be able to finish it. In states like that, or if there is a missing tooth because of caries, because of trauma or anything, there is space, and in order to achieve symmetry, you might have to do something called as a balancing extraction. That is, if a premolar or a molar on one side is missing in the upper arch, you extract the opposite side premolar molar, and this is called as a balancing extraction. Coming to compensating extraction, it is extractions that are done on the same side but between the arches. If there is a missing premolar in the upper arch and you cannot line your teeth, then you will have to extract the premolar in the lower arch and achieve almost ideal occlusion. So extractions of the upper and lower arch are called compensating extractions. Now, what is Wilkinson's extraction? This was given by Wilkinson, and he said that when the patient is between the age of 8.5 to 9.5 years, you need to extract the first molars. This was ideally because he thought that if you extract the first molars, the proclination is corrected, as in there won't be chances for proclination to occur, and also there will be space for your third molars to erupt. The second molars will also drift mesially and stay in the form of the first molars. This was idealized, or this was started way back in the 1800s, but then it's not followed because of one major disadvantage. Whenever you have a Wilkinson's extraction or a prophylactic first molar extraction at the age of 8.5 to 9.5, your second premolars will drift mesially or tipped. Sorry, your second premolars will tip or drift distally, and your second molars will tip or drift mesially. So the space that you gain by your molar extraction, first molar extraction, is almost half or 75% utilized by tipping of the other teeth, and it will not help gain space, or it will not help your treatment mechanics go easier. So serial extractions, I'm pretty sure all of you know. Duell, Tweets, and Nance gave serial extractions. Duell said you need to extract the deciduous canine first, so as to make space for your incisors. Then you extract your deciduous molar, so as to gain space for your erupting premolars. And then you need to extract your first molar, first premolar, so as to achieve ideal extraction in case a first premolar extraction is indicated. Tweets and Nance gave the extraction sequence a little differently. First one being extraction of your deciduous molar, then your premolar, and then your canine, because the canine erupts last in the maxillary arch. And both of them are done for the same reasons as I mentioned before. So uni-arch extractions, I think we discussed. Class 2 upper arch premolar extraction, class 3 lower arch premolar extractions. Unilateral extractions, there is a subdivision extractions that are happening. So extractions as such can be done for various reasons, and this is the next questions that you have. It is of a different topic, and I did not want to put the topic in front because the answer goes straightforward. So the question being, an adult male patient presents with class 1 malocclusion with a crowding of 3 millimeters and a proclination of 1 millimeters. So there is a total space of 3 millimeters for crowding relieving and 1 millimeter of proclination relieving. The patient also presents with rotated 1-4, 2-4, 3-4, and 4-4. So all his first premolars are rotated. So the most conservative treatment approach to reach an ideal occlusion will be option A, an extraction line of treatment, option B, non-extraction line of treatment, option C, IPR, and option D, none of the above. Anybody would want to answer? So there is an adult male patient, there is no growth left, and he has class 1 malocclusion with 3 millimeters of crowding and 1 millimeter of proclination. And he also has a rotated first premolar 1-4, 2-4, 3-4, and 4-4. And what would be your most conservative approach to achieve ideal occlusion? Options again: option A, extraction line, that is extraction of your first premolars. Option B, non-extraction line of treatment. Option C, IPR, and option D, none of the above. So the right answer is non-extraction line of treatment. The space that is required is around 4 millimeters, and when there is rotated posteriors, there is an extra space that is taken up by your posterior teeth. So this question is for you. The right answer is option B, non-extraction line of treatment. Why? We'll just discuss here. So a rotated posterior teeth as compared to a normally placed posterior teeth, sorry for the mistake, a rotated posterior teeth as compared to a normally placed posterior teeth will occupy option A, more space, option B, less space, option C, same amount of space, or option D, none of the above. Sorry for the mistake. Sorry for the mistake in the question. The question is a rotated posterior teeth as compared to a normally placed posterior teeth will occupy option A, more space, option B, less space, option C, same amount, or option D, none of the above. So let me just explain it with picture. The right answer is option A. So in picture A, you can see that your premolar is straight, upright, and you can see the amount of space that it is taking. Whereas when you see the picture below, your premolar is rotated. This is similar to the question that I asked. If there are rotated posterior teeth, not just premolars, even with molars, they occupy a larger amount of space. And when you derotate them, you might get up to around 1 millimeter of space for your corrections. So whenever there is a posterior teeth that is rotated, you can gain space by just derotating it or uprighting them. So the right answer for the previous question is option A. The posterior teeth will occupy more amount of space than a normally placed posterior teeth when you're speaking about the rotated posterior teeth. The next topic on the next way or how to gaining space is molar uprighting. So before we go to molar uprighting as such in detail, we have a picture-based question. So if you can see in the picture, there is a T-loop appliance that is present in the mandibular arch. I want to know what it is used for. So your options are option A, space closure, option B, reduction of proclination, that is retraction of your anteriors, option C, uprighting of molars, or option D, both A and B. Anybody would want to answer? So in the lower arch, when you can see the arch wire, there is a T-loop that is present in between your premolar and molar, and what is it used for? So I'm pretty sure all of you know what T-loops are, and T-loops are used for closing spaces. But then there are various other mechanics and various other uses of T-loop as well. The right answer for this question, and if you observe the picture properly, your molar is not upright. Your molar is tipped mesially. So this T-loop is used for uprighting of your molars. The right answer for this question is option C, uprighting of molars. And if you also notice, if you need to close spaces, your T-loops are usually placed in between the distance between your molar and premolar. But in this picture, your T-loop is placed much more closer to your molar. It means to say there is a lot of force acting on the molar that will help upright the molar. So the right answer for this question is option C, uprighting of molar. And whenever there is closing loops that are present, it will usually be in cases of extraction, and that will be present between your canine and your second premolar. The first premolar space is where your loop is housed. So if you see diagrams of T loops as such, if it is posterior, it can either be for uprighting of your molars or protraction of your molars, depending on where your loop is positioned. You can see it in between your extraction spaces, then it is used for closing of spaces. So do not get confused. A T loop can be used for any method, for space closure, for uprighting, or for protraction as well. It depends on where your T loop is placed. The next question, very simple. Question being, a mesially tilted molar will, option A, occupy more space in the arch. Option B, occupy less space in the arch. Option D, occupy the same amount of space that in the arch. Or option D, none of the above. So the picture is also a clue on what it was. You saw that molar was tilted, and what did it do? Did it occupy more space? Did it occupy lesser space? Did it occupy the same amount of space, or is it none of the above? Anybody would want to answer? Right. So uprighting is a method of gaining space, and if there is tilted teeth, it will occupy more space. Right answer is option A, that it will occupy more space in the arch. And how else can you do uprighting? We will discuss on how it is. Option is answer. Right answer is option A. It will occupy more space. All of you were right. The next question on how you can do it, how you can upright molars. The question is, molar uprighting can be done using the following. What are the appliances that you can use? Option A, open coil springs. Option B, magnets. Option C, pads or temporary anchorage devices that can be implants or your plates. And option D, all of the above. Anybody would want to answer? How would you upright the molars and how can you do it? We've already seen that we can upright the molars with T-loops. So I haven't mentioned T-loops in this image. There are much more methods on how we can upright, and what do you feel can upright molars is the question. Coming back, anybody who would want to answer? Option A is open coil springs. Option B is magnets. Option C is stats, and option D is all of the above. Okay, so the right answer for this question is option B, all of the above. You can upright molars using open coil springs. You can upright molars using magnets. You can upright molar using pads. And we already spoke about T-loops as well. And this is how you can do it. So I think this T-loop is a much more clearer picture on how it works and what it does. So you can see that the T-loop, if there is a space, it is much more closer to the molar. And if it is closer to the molar, we call it that there is a movement on the molar. That means to say that the molar will have a rotatory effect than just, moving mesially or distally. So if the T-loop is closer, then the molar uprighting also will happen. That is the first picture that you can see. The second line of pictures, the one on the left side, is of an open coil spring. This open coil spring is used to upright your second molar in this picture. So there is an implant that is placed. There is a buccal tube that is placed to your second molar, and an open coil spring is given. Something that you need to know: an open coil spring is a spring that is constricted, and when it is placed inside, it will open up spaces. A closed coil spring is a spring that is expanded, and when you place it, it will start closing spaces. Open coil springs are used to upright the molars or to create spaces, whereas your closed coil springs are used for retraction. So the second picture on the left side is a picture of your open coil spring where your second molar is being uprighted. The picture on the next is your tags. There is a tag that is placed in the arch. Preferably, this is placed around your buccal shelf area, and the tag is used to upright the molar. So you can see three ethenes going around and trying to pull the molar, and that is how you can upright. This molar that is tilted will start getting uprighted. So if you have tilted molars, one more method on how to do it with your continuous mechanics or with your fixed appliance is the use of PPAs or the use of non-palatal arches. So I think in the previous lesson, when previous class, there was distalization, and I showed you a particular type of PPA that is used to distalize your molar. So in the same kind, if you can incorporate a force into your TPA, you can either uptight your molars, or in this TPA, you can see there is an extension that is coming out from your first molar toward your second molar. It is a piece of stainless steel wire that is formed on the occlusal surface and made as a hook. There is a button on your second molar, and there is an E10 engaged. So this TPA and TPA modifications can also be used to upright for molars. So in case you see diagrams, any of such, the first one on the T loop, that is towards the molar, it is for uprighting. You can see a lot of elastics going to your molar or any other posterior teeth and implants or no implants. It is used for uprighting. If you can see open coil springs, it is also used for uprighting of your posterior teeth. And if you see TPAs, be very careful to observe if there is an extension, if there is any type of movement given, if there is any type of force given, which usually will be mentioned in the question as well. They all can be used for various purposes, including uprighting of your posterior teeth. Okay, so the last part of gaining space is proclination of anteriors. So coming to the first question on proclination of anteriors, a patient presents with retroclined upper anterior teeth with edge-to-edge bite. The space required is around 2 millimeters, and the best way to treat the patient is by option A, proclination of anterior teeth, option B, extraction of your lower premolars because there's an edge-to-edge bite, option C, extraction of all 4 premolar so that you can manage space, retract your lowers, and then retract your uppers as much as required, or option D, IPR, where you do IPR for your lower incisors, retract them, and then close the spaces. What would be the right answer? A patient presents with retroclined upper anterior teeth and edge-to-edge bite. The space required to correct the occlusion to ideal is around 2 millimeters. The best way to treat it is option A. Option A is the right answer, the proclination of anterior teeth. So how can you procline your anterior teeth I'll just get back to how you procline your anterior teeth. I'll just finish this off. I don't think I put pictures for proclination of anterior teeth. I shall let you know in the references. So whenever there is a edge-to-edge bite, whenever there is a retruded space, and you need to protrude your anteriors, you need to think about it well, and you need to do it in such a way that it is an acceptable limit. That is, it is not too proclined, and it is in compliance with an ideal soft tissue profile. The soft tissue should be straight. It should not be convex. It should not be concave. And even if it is concave and there is a retroclined incisor, you can protract it to make it straight. And whereas while you're protracting it, you can also gain small amount of space also to do your other corrections, such as minimal crowding or getting your molars into class 1 or however you would want it. Okay, so very sorry about the last part. Whenever it comes to proclination of anterior teeth, there are a lot of appliances that can be used. A few appliances being the first one, if we are going about removable appliances, I'm pretty sure all of you have known Z springs. You know how they look. There are T springs. So Z spring and T spring are both removable appliances that can be used to procline your anterior teeth. Not just centrals, can be used for molars, premolars, canine, or laterals as well. When you have your fixed orthodontic treatment, that is when there is braces in place, and there is a similar situation like this where there's an edge-to-edge bite. So braces and your archware itself will sometimes correct your retroclination, or they can procline your teeth. So removable appliances like Z spring or T spring, fixed appliances, that is your fixed orthodontic mechanotherapy, can also procline your anterior teeth. There is also another method of proclining your teeth. I don't think you should go into the detail with it, but just know the name. They're called as anterior root torquing auxiliaries, or they're called as ARTs. Do not confuse this with atraumatic restorative technique. This is an orthodontic term, and it will usually come as root torquing auxiliaries or anterior root torquing auxiliaries, and they can also be used to correct your proclination. Coming to the last question of today's class, the best method to gain space is option A, to extract, option B, to expand, option C, to distalize, or option D, to take a case-based decision. So we have seen 7 methods of gaining space in last class and this class as well. They are IPR, distalization, extractions, expansions, and the other methods: proclination of anterior teeth, uprighting of molars, derotation of posterior teeth. What do you think would be a best method to gain space? Would it be to extract your teeth? Would it be to expand your teeth? Would it be to distalize your teeth, or to take a decision based on the case? Anybody would want to answer this? This is pretty simple. This is very simple. I would want somebody to answer, and we will summarize what all we have learned from last class as well. So the right answer is option D. So if you have a space requirement which is around 2.5 to 5 millimeters, you can easily go with interproximal reduction as your plan of treatment. If you have a space requirement of 7 millimeters or above, you can go with your extraction as your line of treatment. If you have around 2.5 to 5 millimeters of space required, and if you have constricted arches, if you have crossbits, you can go with expansion as your method of treatment. If there is minimal amounts of space required, and if the patient is not okay to get his tooth extracted, if there is a requirement of 2 or 3 millimeters of space, then you can do your distalization as well. Just keep in mind that when you're doing distalization, the third molar should not be present. They have to be extracted, and the ideal time to distalize is before or during your second molar being erupting. You can distalize and gain space as well. And so when it comes to this question, the best answer and the right answer is, until and unless you're not given a set parameter of the case or how the case is, the right answer, if somebody asks you on the best method of gaining space, is to take a case-based decision. So we have around 15 minutes, and if anybody has questions, if anybody would want to ask anything, if you want any clarifications, I'm ready to take it. You can just type in your questions on the YouTube channel, and I would be ready to answer. This concludes our session about methods of gaining space. You can refer to the earlier class where we have discussed about other methods on how to gain space. And this class was basically about extractions, derotation, uprighting of posterior teeth, and the proclination. Anybody wants to know anything? All right then. So if there are no questions, then thank you, Kaunaj, and for the opportunity for me to just present method of gaining space, and to all the NEET aspirants who are there, and to everybody else who is planning orthodontics as a profession, or getting ahead with dentistry. All the best to all of you, and for all the NEET aspirants, I would want to wish all the best. Exams are upcoming, and then perform your best, and hopefully you get whatever you want. Thank you. Good day. See you next class.